Hello everyone. The topic for discussion for today is nausea and vomiting in pregnancy. So, the reference for this topic is from the textbook of obstetrics and gynecology, DC Datta. Now, most common symptom of pregnancy is nausea and vomiting. In approximately 75% of pregnant women, nausea and vomiting is seen. So, it is a very important and very obvious symptom of pregnancy. Now, the causes of vomiting in pregnancy can be divided into two parts. First is the in the early pregnancy and second is in the late pregnancy. Now, in the early pregnancy, it might be linked to pregnancy itself or it may be associated with pregnancy some other things, certain other medical, surgical or gynecological factors which has led to the nausea and vomiting. Now, first of all, we will study with the early pregnancy causes. Now, related to pregnancy, it might be simple vomiting, that is morning sickness, that is seen in approximately 75% of the pregnant mothers. It is called as emesis gravidarum. The second type is hyperemesis gravidarum, that is also called as pernicious vomiting. The incidence is quite a low, 1 in 1000 pregnant mothers. Now, associated with pregnancy, it can be of medical reasons, surgical reasons, and gynecological reasons. In the medical reasons, it might be infections due to urinary tract infections, H. pylori infections, hepatitis, diabetic ketoacidosis, and migraine have been linked with uh, causes of vomiting in pregnancy. Now, in the late pregnancy, it might be related to pregnancy as there is continuation or reappearance of the simple vomiting of pregnancy that is seen in the early pregnancy. It is continuing till the late part of pregnancy. There can be conditions like acute fulminating preeclampsia that might be the reason for the vomiting in the late pregnancy. It can be associated with pregnancy, like medical and surgical and gynecological reasons, like the hiatal hernia, is the reason for such conditions. Now, in the surgical uh, thing for early pregnancy, we have appendicitis. Appendicitis, we all know, has signs and symptoms of nausea and vomiting. So, appendicitis can be there. Intestinal obstruction, cholecystitis, pancreatitis, and gastritis might be the reason for any early pregnancy reasons of vomiting. Gynecological reasons might be twisted ovarian tumor or the regenerative degeneration of regeneration of the fibroid. Or ectopic pregnancy can also be the reason for early pregnancy vomiting and nausea. Now, as I have talked later on also, uh, three-fourths of the pregnancy, that is 75% to 70% of the pregnancy, have this simple vomiting in the early phase of pregnancy. That is also called as the morning sickness and the emesis gravidarum. Now, the chief complaints of the patient are nausea, occasional sickness in the morning, that is morning sickness. The vomitus that is small in small amount and it is clear. There is no impairment of health. This point should be noted that in the hyperemesis gravidarum there is significant impairment of the maternal health and there is restriction of the normal activities of mother. However, in the simple vomiting there is no restriction of the maternal activities and impairment of maternal health. Now, these symptoms generally disappear from 12th to 14th week of pregnancy. The reasons of this simple vomiting is increased level of HCG and estrogen and progesterone. These three hormonal causes are the main etiological factors for the simple vomiting in pregnancy. Now, management. Uh, as this vomiting is very much common in a majority of women, so the first thing is maternal reassurance. So, assurance is given to the mother that this is a normal symptom of pregnancy, and if any deleterious effect is seen, you have to again come to the hospital. This vomiting in pregnancy and nausea in pregnancy is seen to be a fetoprotective mechanism. The mother and the baby are at risk of the baby is of at risk of having any teratogenic infection or any insults. So to protect that growing fetus, to from any insults, environmental insults, the mother is having these nausea and vomiting, so as any harmful substance is not taken up by the mother. Now, the dietary management is also advised to the mother to take protein and carbs, generally dry toast, biscuits, and banana is given to the mother. And the mother is also advised to take small and frequent meals. It is also seen that during the prolonged fasting, this morning sickness is aggravated. So, when the mother sleeps at night, there is a prolonged period of fasting. So, in the morning, the mother faces morning sickness. So, the mother is advised to take small and frequent meals at night, waking up and taking a small banana, biscuit, or toast is often advised to the mother. The mother is also advised to avoid fatty and spicy foods as it can cause gastric irritation and further aggravating the morning sickness. Now, in the case of supplementation, vitamin B1 is given to the mother 100 mg daily, which is helpful. Antiemetics, in cases where the normal dietary supplementations or dietary modifications are not helpful, antiemetics like doxylamine 10 mg twice daily or 4 times daily as per the requirement or the need are given to the mother. The mother is also advised to take plenty of fluid because in the case of vomiting, excess of fluid is getting lost in the vomit. Now, we will be talking about a condition that is aggravated form of this simple vomiting in pregnancy, that is hyperemesis gravidarum. Now, talking about hyperemesis gravidarum, the incidence is 1 in 1000 pregnancy, that is 0.3 to 2% mothers face this hyperemesis gravidarum. The incidence of hyperemesis gravidarum has significantly reduced these days due to proper antenatal care, maternal health, and improvement in the health structure of the government. Now, what is hyperemesis gravidarum? It is a severe type of vomiting of pregnancy which has got deleterious effects on the health of the mother and or incapacitates her in day-to-day activities. Like the maternal health it is having a deleterious effect on the maternal health, and the day-to-day activities of the mother are also deprived. So there is a triad of hyperemesis gravidarum that should be there. First is more than 5% loss of the pre-pregnancy weight. The weight of the mother that was there in the pre-pregnant stage, more than 5% of that weight, if it is lost, then we say it is hyperemesis gravidarum. Signs of dehydration and starvation are seen in mother. An electrolyte imbalance is seen. In the electrolyte imbalance, there might be metabolic acidosis and alkalosis. Metabolic acidosis is seen because the mother is starving, because whatever the mother takes, consumes, she vomits it out. So there is a state of starvation. Proper nutrition is not taken up. Alkalosis is there because along with the food particles, hydrochloric acid is also lost. So there is a state of alkalosis. So these both things, metabolic acidosis and alkalosis, are seen in the body. This chances of hyperemesis gravidarum is highest seen in between the first and the second best periods because the level of uh, human chorionic gonadotrophin, that is HCG, is highest during that time. Now, if we talk about the etiological reasons, it is limited to the first trimester, that is, it is highest in the 9th week and it resolves by the 20th week of gestation. Now, there is increased chances of uh, hyperemesis gravidarum in the priming gravida. And if a priming gravida faces such conditions like hyperemesis gravidarum, there are increased chances that in the further pregnancy there will be chances of again her getting into hyperemesis gravidarum. Younger age, if a female gets pregnant in the younger age, there are, but of course, higher chances of hyperemesis gravidarum that is seen. In the low body mass, if the female is lean, then again the chances of starvation and cachexia and these conditions will be aggravated. Now, if there is a history of motion sickness, we have seen in the maternal changes in the pregnancy that occur in the body of a woman or a mother during pregnancy, is that the inner ear again it it changes the physiology of internal ear changes. So if the mother is having motion sickness, then there is already an altered state of the inner ear. So there are chances that these will aggravate the existing vomiting and nausea. Now, if the mother is having migraine, this again will be aggravated. Now, any family history of uh, her mother or her grandmother are having this similar condition, then again this puts the female at more risk of having hyperemesis gravidarum. Now, it is more prevalent in hydatidiform mole and multiple pregnancy and trisomy 21. So we have to screen the mother for such conditions also, because there are chances that there might be a hydatidiform mole or a multiple pregnancy or a trisomy 21. Now, there are certain theories that have been put showing or justifying the reason for this hyperemesis gravidarum in pregnancy. Hormonal reasons: there is increased level of HCG, we all know. There is increased level of estrogen, progesterone, and leptin hormone also, which has led to this complete physiological process and pathological processes in the body. Now, the progesterone, further on, it causes relaxation of the cardiac sphincters. So as the cardiac sphincter will relax, there are chances that the aggravation of vomiting and in pregnancy will be there. Now, there are psychogenic reasons, but of course, and we have seen when the environment of the mother is changed, the symptoms get relieved on. There are certain odors and certain type of smells the female is allergic to, so it is often advised to not consume or to not uh, cook certain things or not to get in the stimuli of such conditions, of such odors or certain things which the female is sensitive to. Now, certain dietary deficiencies can be there, which can also aggravate this condition. So we have seen that in this stage, the carbohydrate reserves are depleted. So we have also advised the female of taking multiple carbohydrate and protein-rich meals and low-fatty meals, because the carbohydrate reasons are also the carbohydrate reserves are also depleting, which has further aggravated or caused this hyperemesis gravidarum. Now, vitamin B6 and B1 and protein levels are also reduced in the body. There might be any allergic reasons or the decreased gastric motility. Now, there is a vicious cycle that is seen. The female first gets nausea, then it goes to vomiting phase, and there is a carbohydrate and starvation, because the female is not consuming carbohydrate, so there is a state of starvation, which again leads to the breakdown of proteins and fats in the body, which has led to ketoacidosis. This ketoacidosis state again leads to nausea and vomiting, so this entire vicious cycle is there. Now we will be dealing with the pathological changes in the body due to this hyperemesis gravidarum. Now, the pathological changes were described by Sheehan. Now, the changes in different organs are as follows. In the liver, we see the centrilobular fatty infiltration without the necrosis. In the kidney, we see the fatty changes in the first convoluted tubule. In the heart, we see that there is a decreased heart size. Subendocardial hemorrhages are also seen. In the brain, there is Wernicke's encephalopathy. As we have seen, there is deficiency of vitamin B1 and B6, which has led to Wernicke's encephalopathy in the body. Now, there might be metabolic, biochemical, and circulatory changes that are occurring in the body. Talking about the metabolic changes, there is decreased glycogen reserve in the body, so fat is broken down. So via the breakdown of fat, there is development of ketone bodies in the body. Now, these ketone bodies are either acetone, acetoacetate, or beta hydroxybutyrate. Now, these acetone bodies are eliminated or excreted by the body by two methods. First, they can be excreted by kidney, and second is through breath or through lungs. So, we can also judge whether the acetone buildup is there in the urine and in the breath analysis. Protein breakdown is also there. Now, in the biochemical changes, we can see that there is both. We have discussed also acidosis and alkalosis are seen. So there are acidosis, alkalosis, hypokalemia, loss of water, and sodium and chloride is also there, because along with the HCl, the water and the food is also getting vomited out. Now, hyponatremia, hypokalemia are also seen, and hematocrit concentration is increased, and ketonuria and is removal or excretion of ketone bodies in the urine is also there. Now, in the circulatory, there is a thing that is hemoconcentration is there, because it is a state of hypovolemia, because excess of fluid is getting removed from the body. So there is a state of hemoconcentration. There is apparent increase of hemoglobin concentration in the hemoglobin percentage in the body due to this apparent or transient hypovolemia in the body. Now, increased levels of RBC are seen, increased levels of hematocrit are seen. This apparent increase in the hemoglobin percentage should be kept in mind. That is not just physiological, it is pathological, because the underlying cause is hyperemesis gravidarum, or the hypovolemia that is occurring due to the nausea and vomiting. Now, if we talk about the clinical course, it might be early and it might be late. So, in a nullipara woman who is pregnant for the first time, in the early pregnancy, the onset is insidious. Uh, but in the day-to-day activities of the female are normal. There is no as such deleterious effect to the life of the female in the early cases of hyperemesis gravidarum, and there is no signs of dehydration or starvation that are seen. But if we talk about the late stages, the signs of dehydration and starvation are there. Alarming signs of dehydration and starvation are there. The woman is moving towards starvation and dehydration. So there is completely metabolic acidosis, alkalosis that is going on in the body of the female. Now, what are the symptoms with which the female will present to you? That is, increased amount of vomiting, bouts of vomiting will be there with retching. What is retching? Retching is the feeling of to vomit out, the urge to vomit out, but the female is not able to vomit out something from the belly. It is just a feeling of nausea, extreme uh, feeling that such she has to vomit out, but she can't vomit out. Nothing is expelled out or released or excreted from the stomach or content. Now, the urine quantity is, but of course, reduced. We say it is to be an oligouria, that is less than 200 uh, uh, 200 ml of urine per day, due to this hypovolemia that is pertaining in the body. Epigastric pain, constipation is also seen, again due to this very reason that there is hypovolemia in the body. Now, signs which we can elicit and we can see are dry coated tongue, sunken eyes are seen, acetone smell in the breath, because there is production of acetone in the body. The patient is seen to having tachycardia, because increased heartbeat is there, because there is hypovolemia. So heart has to work more to pump the blood or to provide blood to the different organs as well as to the fetus. There is hypotension, again due to hypovolemia. Now, what would be the investigations you will be carrying out? You will be writing down on the paper or jotting down. In the case of hyperemesis gravidarum, first of all, urine analysis is to be done, in which the quantity of the urine will be reduced. Oliguria, dark color urine, specific gravity of the urine will be increased. Acetone bodies will be found in the urine. Protein levels will be high. Pus cells might be present if any case of urinary tract infection is there. Now, in the biochemical and the circulatory thing, we have seen the In the majority of the cases, the liver function test is deranged because there is a state of metabolic acidosis and alkalosis and such. And the entire reason or entire work of this thing goes to liver to metabolize things. So liver is doing a very tedious job here. Now, serum TSH and T3 and free T4 levels are certainly in the state of the woman presents as a state of thyrotoxicosis because the free T4 levels are increased in the body. Now, the ophthalmic examination is important and it is the most unfavorable sign that if any changes in the eye are seen. When we do the fundoscopy, we might see there are retinal hemorrhages and there is a detachment of retina. So these are the most unfavorable signs the case of hyperemesis gravidarum in present to you. Now we have to do ECG because we have seen there are a decreased level of potassium in the body. So potassium is a very narrow thing, should be kept in very narrow limits. So if any changes in the potassium levels is there, the patient might progress to arrhythmias or the cardiac arrest or any other manifestations relating to potassium levels. So this should be kept in mind. Now, first of all, diagnosis should be made that pregnancy is there because we are talking about the early pregnancy. So might be there the female is not detected with signs of pregnancy, or there is not a detected case that it is the mother is pregnant. Now, ra- after diagnosing that the mother is pregnant and the reason for this vomiting is not any other cause but the pregnancy itself, then we have to go further on. We have also to rule out that it is not any hydatiform mole, any multiple pregnancy, any ectopic pregnancy, any trisomy 21 which is pertaining in the body of the mother, because such things also cause increased level of HCG, which can also cause hyperemesis gravidarum. Clear? Now, what are the complications we generally see in such case? First is the maternal complication and the another is the fetal complications. So first let's cover the fetal complications. First is the low birth weight fetus and preterm birth can be there. In the maternal body has furthermore complications, and it has got, we have seen that it has got deleterious effects on the maternal health first of all. So first is the Wernicke's encephalopathy and beriberi. These both things are due to the vitamin B1 levels that have reduced in the body. Now, pontine myelinolysis, Korsakoff psychosis is there, stress ulcers and esophageal tear and bleeding, Mallory-Weiss syndrome is seen because when the mother is uh, doing vomiting and bouts of vomiting are coming, then there might be chances that the esophageal tear is there. So that is bleeding and vomiting is seen. So that is Mallory-Weiss syndrome. Jaundice and hepatic failure will be seen because the liver enzyme, we have said that they are already deranged. So there might be chances that the female might proceed to jaundice and complete hepatic failure. Now there might be chances that convulsions and coma may present as the neurological complications of this hyperemesis gravidarum. Now, what are the preventive things that you should, as a doctor or as a female also, a mother should keep in mind or you have to advise her? Now, small and amounts and frequent meals should be taken because we have seen that when there is prolonged fasting, the morning sickness is increased, the vomiting is increased. So the female is advised to take small but frequent carbohydrate and protein rich fatty acid or fatty food should be reduced. Fluid things should be increased in the diet. Such food should not be taken which irritate the gastric mucosa, which led to irritation and again vomiting. Such foods which have which elicit or which again cause nausea to the female, such food or odors should be kept aside, should not be taken, should not be smelled. by the female. Now we have come to the most important part of this chapter, that is management of hyperemesis gravidarum. The first thing of you is to hospitalize the patient. Now, uh, medications might be started if there is a protracted nausea vomiting in pregnancy despite oral antiemetics you have given, but there is no signs of uh, st- disappearance of dehydration or starvation in the female. There is continued nausea vomiting in pregnancy with ketonuria, and there is weight loss of more than 5% of the pre-pregnancy weight. Then you have to keep in mind any comorbid conditions might be there. Then you have to again hospitalize the patient and again go with the medications part. Now the female should be kept nil per oral 24 hours after the vomit stops. Then you have given her antiemetics and the vomiting has stopped. Then there after 24 hours you have to keep the female on nil per oral. You have to continue the food and the fluids through IV line. Fast hydration IV therapy is given to the female because she has presented with signs of dehydration and starvation. So 3 liter of fluid is uh, given to the female through IV line, 1.5 liter with 5% dextrose and thiamine. If you are not giving thiamine to the female, you are doing a crime. You may be sued because you might progress the female to Wernicke's encephalopathy if you are not giving thiamine. So 1.5 liter of Ranger lactate is also given, and this should be kept that along with this 3 liter you have to calculate the urine output and the vomitus output of the female, and it should be added and again added to this 3 liter and given to the female. Now if we talk about the antiemetics which should be given, or which in this case they are must because the vomiting is not stopping. So doxylamine, 10 mg, OD, BD, or 4 times a day are also given as per the requirement of the female. If the vomiting stops, then you have to discontinue this or you continue at the similar pace. And if the vomiting is not controlled by the dosage, you have to add on the dose. Clearly, along with doxylamine, vitamin B6 or pyridoxine is given 25 mg because again this thing, vitamin B6 is important to prevent the Wernicke's encephalopathy. Now second line drug is metoclopramide, 5 to 10 mg, 8 hourly. IV or IM can be given, orally can also be given, but you have to keep in mind what are the circumstances you are dealing with the female. Hydrocortisone may also be given in case the vomiting is not getting stopped. Take care. Now ondansetron is a safe drug. If you have to add it or the female is not responding to doxylamine, you can add cetrons, ondansetrons, but pantoprazole is not given. Okay. Now parenteral thiamine is also given to prevent Wernicke's encephalopathy. Now signs of improvement, that yes, we have given the treatment, we have managed the case, but what are the signs that the female is showing improvement or we are going in the right direction? Now the signs are subsiding of vomiting. The vomiting subsides. There is feeling of hunger. The woman was in a state of starvation. She was not able to eat. So the female wants to eat. There is a urge of hunger. Now the female looks better comparatively. There is normal urine output. There is normal pulse and BP which was lowered on the lower side. Disappearance of the acetone from the breath is there and normal blood biochemistry is there. So if you get to this topic of hyperemesis gravidarum and you have a clear idea what to do in a situation when you face a case of hyperemesis gravidarum on nausea and vomiting in pregnancy, then subscribe to my channel for further videos, like the video, comment, and I will be waiting for your comments, your feedback if you want to give any, and do share with your friends so they can also learn this important topic of hyperemesis gravidarum. Thank you.